Hello, my name is Wei Chen. I'm associate professor in the Department of Medicine and in the Department of Developmental and Molecular Biology at Albert Einstein College of Medicine in New York City. Thank you for having me join your conference in bone and joint disease and age. I'm excited that I'm able to share the calcium paradox in relation to kidney disease. My title is Calcium Maldistribution in Kidney Disease. My disclosure includes my employer, and I do receive research funding from National Institutes of Health. This is basically the overview of my talk today. I'll be describing to you chronic kidney disease and mineral bone disorder, or abbreviation is CKD-MBD, which is manifest by either one or a combination of the following. First is abnormalities in calcium and phosphate metabolism. Two is anomalies in bone turnover, mineralization, value, linear growth, and strength. And three is the vascular or other soft tissue extraskeletal calcification. First, start with some epidemiology. The kidney disease is very prevalent and rising globally. This is an epidemiology study from 1990 to 2016 that shows the incidence and prevalence of kidney disease has been rising due this time, increased by close to 90%, with 276 million people with kidney disease. The death contributed to kidney disease has also increased to increased by 98%. Before we go on, I would like to give a shout out to our nephrology colleagues in Ukraine. As of January 2021, around 11,000 patients in Ukraine had kidney disease that required dialysis treatment. Thanks to the heroic sacrifice of all healthcare professionals and efforts of dialysis provider, most of these patients were able to continue to receive dialysis treatment during the war. As described in this article, these efforts, including having patients, families, and staff living in a dialysis unit for whole 3 weeks, barricading windows and doors and transfer patients to basements. These situations and measures are certainly unimaginable to most of us. So thank you to all of you. And so the maintenance of physiologic level of calcium and phosphate involve negative feedback loops among kidney, parathyroid gland, bone, and intestine. The hormones that involve in these regulation includes parathyroid hormone, which increase renal calcium reabsorption, increase bone resorption, increase calcium production, and decrease renal phosphate reabsorption. Also includes calcitriol, which increase the intestinal calcium absorption and intestinal phosphate absorption. And lastly, this bone hormone, fibroblast growth factor 23, or FGF23, that increase phosphate excretion and decrease PTH and calcitriol. Both parathyroid hormone and fibroblast growth factor 23 are considered phosphaturic hormones, so they help the body lower the phosphate. For this part of the talk, I would like to focus on the function of kidneys, which help excrete calcium and phosphate, as well as produce calcitriol. As kidney function declines, disordered mineral metabolism develop. These includes a decrease in urinary excretion of phosphate, leading to hyperphosphatemia, as well as increasing serum level of fibroblast growth factor 23, and decrease in production of calcitriol. Both the decrease in serum level of calcitriol and increase in level of phosphate also can both lead to decrease in ionized calcium levels. Ionized calcium level is the main stimulus for parathyroid level secretion, thus hypocalcemia lead to development of secondary hyperparathyroidism. The elevation in FGF23 and parathyroid levels is an adaptive response to maintain physiologic level of these divalent ions of calcium and phosphate. However, the elevations of parathyroid levels eventually becomes maladaptive and the secondary hyperparathyroid levels, but hyperparathyroidism develop. These abnormalities are linked to multiple adverse outcomes in kidney disease, including vascular calcification, osteodystrophy, cardiovascular disease, and ultimately mortality. For this part of the talk, we'll be mainly focusing on the development of vascular calcification and renal osteodystrophy. So the many factors contribute to vascular calcification. Here, one of the factors that contribute to it is the hyperphosphatemia or phosphate load can contribute to vascular calcification. This is a sagittal view CT scan of a patient with kidney disease, demonstrating significant aortic calcification, almost obstructing the lumen of the aorta. This is one of the animal studies that demonstrates phosphate loading and kidney disease promotes vascular calcification in rodents. Here you see on the top first two rows are the alizarin red staining of the mouse arteries. Alizarin red staining stains red when there's calcium deposition. So what they did was they induced kidney disease in these mice by using 5/6 nephrectomy, fed them with high phosphate diets, and as you see here, compared to mice who were fed with normal diet and had normal kidney function, those received high phosphate diet and had kidney dysfunction developed significant calcium deposits in multiple beds of arteries, including abdominal aorta, carotid, iliac, and mesenteric artery. This is one of the many studies in early 2000s that demonstrate the effects of hyperphosphatemia or phosphate load on the development of vascular calcification. And kidney disease patients also receive exogenous calcium load. These can be in the forms of calcium-based phosphate binders, such as calcium acetate, and then also calcitriol treatments in order to elevate the vitamin D levels, as well as these patients on dialysis also receive a great influx of calcium during the dialysis treatment. Together with the calcium load and phosphate load, vascular calcification developed in kidney disease patients. And it's very prevalent in kidney disease. And this graph basically shows that the more advanced the kidney disease, the greater the prevalence of vascular calcification. So greater prevalence of vascular calcification arises when kidney function declines. In one of the studies involving people with kidney disease, stage 3 to stage 5, so before dialysis, they found that 79% had some form of vascular calcification. And in one of our study that involving people on hemodialysis for less than 6 months, we found 63% had coronary artery calcification and 50% had thoracic aortic calcification. Vascular calcification were not only present in older adults with kidney disease, but also in young adults. Here is the x-axis is the age, y-axis is the classification scores. As you see here, classification scores start climbing as young as age of 20. Why is vascular calcification important? Vascular calcification has been associated with high cardiovascular mortality, as demonstrated here in meta-analysis of around 200,000 patients with after the mean follow-up of 10 years. What this is showing that if you, for someone with presence of vascular calcification, was associated with 2.6 times the odds of dying from cardiovascular disease. This magnitude of association was even more inflated in people with kidney disease, with the odds ratio went up to as high as 6. Again, this is a Kaplan-Meier curve that's showing the differences in survival in people with kidney disease, comparing those with and without calcification. With people with calcification has much lower survival rate. Why does this matter? Because a lot of people, most people with kidney disease, they don't die from kidney failure itself, but instead they die from cardiovascular disease. Here is here's a graph that comparing the cardiovascular mortality in general population. These are in solid dots, and with comparing those with kidney failure treated with dialysis, and these are arrow dots up in the top. And then they comparing among these different age groups. What they found is, not surprisingly, in general population, as one ages, the cardiovascular mortality increase. But in dialysis patients, the mortality rate start off very high, even among age group of 25 to 34. In this group, as you see here, these people, young persons around 25 to 35 on dialysis can have the same mortality compared to the general population in age group of 70s and 80s. So so far I've discussed about kidney disease leading to disorder mineral metabolism, which then contribute to vascular calcification, causing cardiovascular mortality. Next, let's talk about renal osteodystrophy, which can be caused by hyperparathyroidism, as well as altered osteocyte differentiation and function, as well as inflammation associated with kidney disease. It's important to have bone quality, and then the bone quality is under the control of multiple systemic and local factors that stimulate or inhibit bone formation, mineralization, and resorption. Renal osteodystrophy is a complex disorder due to metabolic and hormonal disturbance that impairs bone quality as kidney function declines. Renal osteodystrophy can be classified histologically into several disease subtypes based on the turnover, mineralization, and volume of the bone. Here we have adynamic bone disease, osteoitis fibrosa, osteomalacia, and mixed uremic osteodystrophy. Osteoitis fibrosa is characterized by increased bone turnover and typically due to increased parathyroidism, or secondary hyperparathyroidism in kidney disease. This can be treated with improved in parathyroid hormone control. And whereas adynamic bone disease and osteomalacia are characterized by low bone turnover, adynamic bone disease is often caused by excessive suppression of parathyroid glands. So it is important to keep a parathyroid hormone within a certain range, not necessarily to a normal range. All of these renal osteodystrophy can cause very poor bone quality. and ultimately result in high incidence of fracture rate. This graph basically showing the higher incidence of fractures as the kidney function declines. The x-axis, as the x-axis advances to the right, is the kidney function declines. The y-axis is the incidence of fracture. Here, you can see in different age group, despite age 40 to 65 or age greater than 65, as kidney function declines, the incidence of fracture increases in both age groups. Same findings were seen in men as well as women. So I have so far talked about kidney disease leading to abnormal mineral metabolism in calcium and phosphate. It can lead to vascular calcification and as well as abnormal bone quality, both of which can lead to mortality. Now let's briefly talk about these bone vascular access. And may not be surprising to this group, many studies have shown that high bone mineral density is actually associated with a slower progression of vascular calcification. And this is one of the recent studies involving people with various levels of kidney dysfunction. They repeated the coronary artery calcification after 4 years and basically found those who had higher bone mineral density was associated with lower risk of accelerated coronary artery progression with adjusted odds ratio of 0.75 and significant p-value. Now let's talk briefly about treatments of kidney disease and mineral bone disorder. So basically, current management of this disorder focus on controlling the serum calcium, phosphate, vitamin D, and parathyroid hormone. For now, these are suggested targets to correct vitamin D level greater than about 32 nanograms per milliliter. Parathyroid hormones can be variable, depends on the degree of kidney dysfunction. Calcium and phosphate, we aim to correct it to a normal assay range. For vitamin D, we emphasize on vitamin D repletion using either ergocalciferol, cholecalciferol, or activated vitamin D. For parathyroid hormones, we would like to, besides correcting calcium and phosphate, we also like to replete vitamin D and use calcium mimetic in dialysis patients. And in those having tertiary parathyroidism, we would suggest using parathyroidectomy in those who has no contraindication to it. To control phosphate, we often use phosphate binders and consult on dietary phosphate intake. For calcium, we will replete with vitamin D, and its emphasis is made to limit exogenous calcium intake, which including restrict calcium-containing phosphate binders and limit high calcium bath in the dialysate. For the management of vascular calcification and renal osteodystrophy, unfortunately, there's not much. For vascular calcification, besides reversing the biochemical abnormalities, we focusing on limiting the exogenous calcium. For renal osteodystrophy, we aim to control the parathyroid hormones by suppressing it if the bone biopsy indicates high bone turnover, or reduce parathyroid hormone suppression if this low bone turnover disease. It is important to note that these therapeutic decisions should be made based on the trend rather than a single laboratory values, and depends on the severity of kidney disease. These practical guidelines are largely based on observational studies, and unfortunately, there is no randomized control trials that demonstrate correcting these abnormalities reduce mortalities. In summary, patients with kidney disease have anomalies in calcium and phosphate metabolism, along with other complications of kidney disease. These abnormalities contribute to the development of vascular calcification and renal osteodystrophy, and which could both lead to mortality. Treatment options are limited, and currently there's no randomized control trial that demonstrate correcting these will reduce mortality. And lastly, more research needs to be done to investigate these calcium maldistribution and bone vascular access in kidney disease. Lastly, I would like to leave you with these new kid on the block, calcium-supporting particle, which is being the center of the investigation right now in terms of their role in the development of vascular calcification as well as bone disease. What are these particles? These calcium-supporting particles are nanoparticles that are composed of calcium phosphate crystals along with inhibitors of calcification such as phenytoin A. These initially forms the calcium-supporting monomers, which is likely the most common circulating form. Calcium-supporting monomers are normally excreted by the kidneys, but in the setting of kidney dysfunction, calcium-supporting particles monomers can accumulate and transform into these primary calcium-supporting particle, which can induce vascular inflammation as well as endothelial injury. When even perhaps in the site of the vascular injury, calcium-supporting particles can transform from primary to secondary calcium-supporting particle, which can induce, in addition to inflammation and endothelial injury, can induce smooth muscle cell calcification, as well as to stimulate osteocytes to increase the fibroblast growth factor 23. Investigations are still ongoing, but this could be a new therapeutic target in terms of solving this bone vascular access and solving the calcium maldistribution in people with kidney disease. And then lastly, I would like to thank you all for this opportunity to share some of these work with you. Thank you.